Good morning, everyone. This is Evelyn. Thank you guys again for your participation and your attentiveness to the webinars. So that's great. We're going to talk about for the next 45 minutes or so the infection control issues related to construction and renovation. Talk a little bit about water management and mold remediation as well. I'm sure those of you that have been doing this for a while that are not brand new have probably had an opportunity to work some with your construction folks at your facility, so you'll have some insight into what we're going to be chatting about. Let's see here. So some of you may not know who Judine Bartley is or was. She actually expired in 2011, but she was certainly an APIC member, a member of SHEA, and was a pioneer in environmental safety, sitting on HICPAC and helping to author the what used to be the AIA guidelines and now are the FGI guidelines for construction and design. And Judine had a real passion for making sure that everything related to construction activities was done correctly. And she had this comment that she had the premise that patients can leave the hospital sicker than when they arrive if construction crews do not do what they're supposed to do. In fact, she notes that it's estimated that there are at least 5,000 construction-related infections that occur every year in healthcare. And as we know, all of those infections, there's a very good chance that all of those could have been completely prevented. I know that Dr. Van Dyne went through some of the problems with construction issues, especially in the immunocompromised host. But I wanted to share some additional information with you related to that. And this is just a little overview of some of the invasive aspergillosis infections that have occurred and what the incidence looks like. And I think one of the most important things is if you look at the mortality, that in each one of these groups, not only in hematological groups, but also in transplant groups, the mortality rate is extremely high. So we all know that these individuals do not do well if they acquire a fungal infection because they are at such great risk of that happening if they're exposed to those agents. One of the first things that we want to do or really remember is that there's been lots of documented cases and lots of documentation that spores are certainly present in construction settings and in renovation works. And that can range anywhere from very large projects to simple renovations in your facility, such as removal of suspended ceiling tiles. A lot of maintenance people and construction people will not see the risk in that. They believe they can disrupt those ceiling tiles and remove them and it not require something like an ICRA or barrier containment. But spores actually are alive and well in lots of different areas of our facility, and we need to be very conscientious about when those materials are disturbed or removed in some manner. One of the things oftentimes we forget about too is if there's construction going on outside of the facility, we may think that there's no need for an ICRA in that case because it's not happening in our walls. For instance, landscaping that's going on with planting of new plants or those kinds of activities, you really do need to take a lot of care and make sure that that activity is not going on where there may be a ventilation supply of air coming into your facility that's close to that outside activity. And then also talk with your maintenance folks and look at their ventilation action plans. How often do they have those on routine maintenance? And are they changing out the filters like they should and addressing some of the maintenance issues? And especially, I'll tell you one little war story. One of the facility I worked with had contracted all of their maintenance of their HVAC system out to a contracting company. And unfortunately, way too late, they determined that the contracting company had not met all of its obligations and had not been changing the filters appropriately, and they wound up hugely expensive project of actually replacing the ventilation, some of the ventilation system components because of routine maintenance that just had been being done as they thought it had been. And so if you contract that service, just make sure someone inside your facility has the knowledge and the expertise to make sure that all of that's taking place. And then this is just an example of what I mentioned earlier of something going on outside of your hospital walls. This happened between March of 1990 and February 1992, where a children's hospital in Toronto experienced 8 cases of invasive fungal sinusitis. And unfortunately, 5 of those children died as a result of that. And all the construction activities actually were going on outside. But they did identify the cause was elevated spore counts that was associated with the excavation site and preparation activities during hospital construction. So certainly this is not something that we want to have happen. And then another little outbreak that you know seems a little bit more uncommon, but makes the point that it certainly can happen. These are some supplies that were actually brought into the central distribution area, you know, in cartons and boxes and containers. And the central distribution area was undergoing some construction. So some of the packaging materials of these wound supplies became contaminated with aspergillus or aspergillosis. They were transported up to the clinical areas, one being the burn area and a surgical unit. And they actually had 4 cases of infection as a result of the outside packaging being contaminated with dust. So it certainly does make the point that we need to be aware of where our supplies are coming in from, and that they are clean and not contaminated when they make their arrival up to the clinical area. Dr. Ritala and colleagues at UNC published a paper a few years ago, and I think he's probably going to discuss this in more detail tomorrow. But they conducted a review of fungal outbreaks that had happened in healthcare settings during construction and renovation activities, going all the way back to the mid-70s. So in this little graph that I comprised, I sorted those outbreaks in 5-year increments. And you can see that the total number of outbreaks ranged anywhere from 1 all the way up to 6. But the number of infected people varied quite a bit. Now, in some of these outbreaks, we're not sure, or the number of deaths are actually unknown, but it's believed that the overall mortality was similar to what we saw earlier and exceeded 50%. If you'll notice in the graph, between 2001 and 2005, there was a pretty big uptake of the number of individuals that were infected. This actually was a result of one outbreak that happened in 2002 and involved neutropenic patients with hematologic malignancies. And there were actually 113 patients that became infected as a result of that. So some of the control measures that the facility in this particular outbreak put into place are things that we know probably should have been in place to begin with. And one of those are barrier protection. And I would recommend that if you're doing construction and renovation in your activities, and there are immunocompromised hosts, and I know all of our patients now in acute care pretty much are at risk in some way, but we do have those that are much more susceptible and immunocompromised, that you'd really want to advocate for dry wall barriers rather than plastic barriers. Those of you that have rounded in construction areas where there's plastic barriers, you know all the problems with that. It doesn't really seem to matter how many signs you have up that say do not enter. There's always going to be some curious person who's going to want to see what's behind that plastic barrier. And then the other issues with plastic is it is heavy, and even if it's secured appropriately to begin with, it has a tendency to separate from the ceiling and or the floor, allowing some venting and some air movement related to that. So again, I would try to advocate for that in any situation that you possibly can, especially if there's going to be construction activities in areas where you're serving immunocompromised patients. Some of the other control measures that they instituted to stop the outbreak were also to service the area with laminar airflow, HEPA filtration, as well as require patients that were leaving their rooms to wear respiratory protection along the lines of an N95 mask. And I think those are probably procedures you guys all have in place in your, especially in your oncology units and oncology areas, but just, you might just want to go back and take a look at those and review those. And then what are some other kind of bodies that speak to us about what we should do related to construction and renovation? Well, certainly most of you, I would imagine, are accredited by the Joint Commission, or there are several other. DMV out there is another group now. There's several groups that are doing healthcare accreditation, and I believe they all have very similar standards. And the Joint Commission does require that we manage the environment in a manner that's going to reduce the risk to the organization, as well as reduce any sort of risk to our patients. And they very clearly in this environment of care standard say that you have to follow some sort of design criteria, and that design criteria may be what your state rules and regulations say. And in North Carolina, and as I'm sure you do in all of the other states that we have represented, you have licensure rules. And part of the licensure rules dictate to you exactly what each one of your units and or departments in your hospital should look like as far as space and fixtures and structural design. So you might just want to take a look at your state rules and find out certainly your plant ops people and your construction folks within your department, your environment of care folks would certainly have a copy of those state rules if you do not have a copy in your department. Another design criteria that the Joint Commission says you can follow is the FGI guidelines. Again, these used to be called the American Institute of Architects, or the AIA guidelines, and that changed over probably about 5 years ago now. And as Judy mentioned earlier, they did this year change that up, and they now have a separate guideline for hospitals, one for ambulatory care areas, and then one for residential care, which includes long-term care and adult care, adult day care. So there are actually three reference books now for you to look at if you indeed have responsibility for all of those types of areas. And then a Joint Commission says if those do not meet specific design needs of your facility and your construction activities, then there are some other reputable standards that might suffice as well. As I mentioned, in North Carolina, we do have our licensure rules, and this is the construction requirements. And the one you see on your slide is just an example of the one for the medical, surgical, and postpartum care unit. They have one of these for other areas of your facility, such as your emergency department, radiology, surgical suite. They also have a section in your licensure rules about infection control that we'll mention again in just a minute. So review your state rules and be familiar with those so that you'll have that knowledge and expertise when you're meeting with the construction folks and the architects, and you'll feel like you really know where what regulations support your recommendations to that group. This slide just shows a picture of the FGI guidelines. They, again, as Judy mentioned, they are not free. They're not real cheap. They're not as much as some other resource documents that we need and that we have to purchase. Someone in your facility should have a copy of these. If your budget doesn't allow, it'd be great if you had a copy in your office, but if you don't, I'm sure someone does, and I'd make friends with those people and make sure that you can borrow it and use it for a reference whenever you need to. And they really used to not update them as often as they are now, but I know in the last couple of years they've actually updated these guidelines every year, so that can get a little pricey. Then also in the Environment of Care Joint Commission standards, they specifically say not only that you need to reduce the risk to your organization, but that you must conduct a pre-construction risk assessment for infection control, along with other hazards that impact care, treatment, and services. And that there must be an infection control risk assessment that's incorporated into this process. So first of all, we have Joint Commission saying that we need to incorporate an infection control risk assessment. And then the FGI guidelines in 2018 address this issue as well. And they also detail what those assessment components should look like. One of the most important things I think that's on this slide is that it's proactive. I actually wish I could kind of get a show of hands of how many of you guys are actually involved in your ICRA at the design phase, because that's when you should be involved, not all the way down to when they get ready to build, but you should be involved in those architect meetings in the design phase. It should be very proactive. There are lots of horror stories where infection prevention was not involved, and a particular area got built and they realized they didn't have any hand washing sinks in the room. So they had to go back and add those. So try to once again make sure that everyone knows you need to be involved at that phase. And I know that this is difficult because you can oftentimes get a lot of pushback, but you have a lot of regulations and a lot of guidelines that support your position on that. So I would really, really try to make that happen. And then it should be very multidisciplinary, involving infection prevention, certainly representatives from the areas that are going to be involved, administration, your construction folks. There's always an architect involved in those meetings as well. And I think one of the reasons sometimes as infection preventionists, and I'm speaking a little bit from experience now, in the past might have hesitated to be part of this process is, I don't understand blueprints. I mean, I'm really visual, and if you take me to the area and you tell me what's going on, I can get that, but I struggle a little bit with blueprints. So I've gotten a lot more comfortable with it now because I know that that's something that we need to be involved with, and we need to address. One of the things that you really want to think about is how your patients are going to be. If you're doing construction in a patient care area, how's that going to look? Are you going to have to move them? If you do, how are you going to move those? Other things that the FGI guidelines talk about as well, not just infection prevention risk, but there are other risks like falls, the medication era rate, and doing a safety assessment looking at medications, as well as security breaches. So if you've got some construction going on, that may pose a security risk for your facility that you hadn't really thought about. And then certainly any sort of behavioral or mental health risk that might be involved with that as well. So the guidelines, the FGI guidelines, are very specific about what should be included in that overall safety risk assessment component, which is actually more than just the infection control piece of it, but it involves all of these other activities that you see. So once we know that it must be proactive, it also must be multidisciplinary, then each one of these safety risk assessment components need to be documented in some format. So for our infection control risk assessment process, we have a very good tool that I'm sure most of you are familiar with, that we're going to go through a little bit step by step. But this is a very standardized, documented, or process to document exactly what's gone on with your infection control risk assessment. It helps you look at what those safe design elements include. It also helps you identify not only your internal areas that are going to be affected, but some of those adjacent to the construction area or some external areas. Also, what are your risks related to airborne and waterborne contaminants? What's the risk of transmission of any of those agents? And then once you've identified those key elements, how are you going to develop your risk mitigation and recommendations for action plans? So I think when we get to the ICRA format, it's going to look really familiar to all of you guys that have been involved in this process. So when we look at trying to plan a safe design element, if you'll remember on that little questionnaire that goes along with this standardized ICRA, it asks the question, what are the number and the location of your airborne infection isolation and your protective environment rooms? Most often, your number of airborne infection isolation rooms may be dictated by your TB risk assessment. However, some states, again, in their licensure rules, has a requirement, and in North Carolina, we do. In the licensure rules, we actually, or they note that airborne infection isolation rooms must be provided at a ratio of at least one isolation room for every 30 acute care beds. So for those of you that are maybe new to this in North Carolina again, but I'm sure, or I would think that most states have a similar statement in their licensure rules, you might want to just go back and look at your total number and see if that recommendation is being met. And your state design, can't remember the name of the group that comes out and inspects before you open up a new area that you've done construction on, but they're very helpful, and they will give you some additional information out of Raleigh about where you are with that process and what that looks like. You also need to consider what your HVAC needs are going to be, how many areas that may require some sort of special HVAC need, like your operating rooms, your surgical suites, the pharmacy. We heard yesterday about the clean room and how many air exchanges they're able to achieve at UNC, which is enormous in that space. So certainly they had to look at those HVAC needs and in order to make that happen. And then the other thing when you think about HVAC is how many areas are you going to have to try to meet negative pressure guidelines, not only for your isolation rooms, but are there any other areas like your laboratory or even in your pharmacy that you might need to exhaust some sort of hazardous fume or material? So when you think about negative pressure, the decontam area in your central processing department, there are a lot of areas that require some negative pressure. So when you think about that, think about areas other than just your airborne infection isolation rooms. Clearly, the number and location of your hand washing stations, and if you're going to have hand sanitation dispensers, where they're going to be located, what does that number look like? How's this going to impact your water system? We found out this week that we take water pretty much for granted, but if you impact that water system, either by shutting it down for a period of time, what is that going to look like? And even if you don't have to shut the water system down, is there going to be any risk of Legionella or other opportunistic pathogens that might be waterborne that would have an impact or maybe expose your patients during this construction activity? And then surfaces and finishes, designers and decorators will sometimes want to choose those that are more aesthetically pleasing. And again, we should voice our recommendations about those surfaces and finishes need to be cleanable. They need to be durable. Because especially in our patient care areas, they're going to undergo a lot of cleaning and disinfection. So they should be surfaces that do not support microbial growth. That is, that they're not porous, they're smooth, they're seamless. So those are all recommendations that they need to consider when you're thinking about the surfaces and finishes within your new construction and or renovation areas. So this is just a schematic of what some spaces look like and some implications of how well the design is laid out. A little bit typical of a blueprint over, if you're looking at the screen over on the left-hand side. You always want to try to plan to have the sink as close to the door as you possibly can for lots of reasons, which you see in the lower photograph as well. If it's back in the corner, and I think we have a picture of that later, but it needs to be readily accessible, and especially if they're in isolation in an area that's going to be close to exiting the room. So this is the other photograph that I wanted to show you. In this particular ICU room, the sink is way back there in the corner, and you couldn't get to the sink even if you wanted to. So this actually fails as a room design. I think the other note about the sink being back in the corner and really not accessible is that if anyone did actually get back there to clean their hands in that sink, there's a pretty good risk that it might be contaminated. It's right in the middle of all the patient care activities. We're learning a lot more about sinks, and we already know that there are certainly outbreaks associated with sinks. So we're learning a lot more about how safe are the sinks that we're asking our healthcare providers to clean their hands in. And that's kind of another talk. So some of the next considerations after looking at the design phase are to plan for your internal and external areas that might be affected. Are you going to have to disrupt essential services, that being the HVAC system, along possibly with water or other essential services? How are you going to transport your construction materials into the site, and then how are you going to remove those construction materials? Have you identified the pathway? If you have to go up and down or use an elevator, can you dedicate an elevator just to construction activities? Some facilities can accommodate that and others cannot, just because they don't have the resources to do that. Not only when you think about protecting your patients, also think about protecting your visitors. Even though the patients may not be housed in that location, are they going to have to travel through the construction area, patients and or visitors, to get to radiology or to go to to the gift shop or to the cafeteria or some other location in your facility? So think about those routes of transporting patients and visitors and how you're going to protect them. And then construction activities, do you allow your construction staff to go into your cafeteria to have lunch? And if you do you have some policies and procedures that they're educated on, that they have to maybe wear a bunny suit when they go into the cafeteria, or wear a bunny suit prior to that and take it off, or something of that nature, just so we're not distributing or carrying construction dust and fomites and other materials on on their clothing. So really think about what kind of, and sometimes we don't think about that until you go into your cafeteria and there they are eating, and they're covered in dust from their drywall that they just put up. So really think about all of those areas of mobility and movement of patients and debris. And then if there is a spill, have they been educated on how to clean that up? So, and I do want to mention, just in case I forget it, a lot of times construction, you'll have contractors, subcontractors, and subcontractors. And how you navigate all of that as far as infection prevention training. And it's not just infection prevention, they've got to be trained on your codes and what the fire alarm means and all of those other things. But that's very difficult to navigate, because a lot of times you don't see these people. They come in and work third shift and you don't even know they're there. So you have to have a strong supervisor in your construction department that's going to make sure that all of those areas get covered, and that all of these individuals, for their safety as well as the organizations and the patients, but for their safety as well, they need to be oriented and educated. So then we're down to the risk mitigation of where you're going to move patients. Obviously, if you're doing construction renovation, the best scenario is to actually have the patient removed from the area if possible, right? To relocate them. That doesn't happen all the time. You may have to renovate your OR and still use your other OR, so that increases the risk and also increases the need to plan. But you do need to think about if you can relocate your patients. Barriers, we've already talked about that. The drywall barriers are best if they can be used, especially for big projects. You do need to consider temporary phasing of the HVAC. If that has to be disrupted, do it in phases and not take everything down at one time. And then protection from demolition, obviously. And then, as I mentioned, the training that needs to take place not only for the construction workers, but for healthcare workers that might be working in that area. And then if you do have a utility outage, what's that going to look like? What are you going to have to do? You have some backup supplies, or what's that going to look like? How many generator outlets do you have? The red plug outlets where you can use for critical equipment. We've already talked about assessing how debris is going to be removed and what that traffic flow looks like. And then on this slide is the point about where are the construction workers going to be able to utilize bathroom services as well as food. And we need to think about how we're going to protect everyone and the facility from some of the building material that gets transported via clothes and shoes and via other mechanisms. And then the last little thing in risk mitigation is to actually have a written plan. For your real participation in ICRAs and in construction activities, you're going to have administrative support for that, where they're going to back the fact that you need to be involved, especially at the beginning. And the governing body really has oversight of all of those activities. Obviously, they dedicate that down through administration. But you should work in collaboration with your hospital epidemiologist if you have one. If they're not titled an epidemiologist, whoever the chairperson of your infection prevention committee would be an excellent resource for you. Construction coordinators, the safety officer in your facility is a great resource and someone who would certainly collaborate with you on how to mitigate some of these risks. Outside consultants are great. Make sure that they dealt with healthcare issues before. A lot of them have experience in residential construction, but maybe not healthcare facilities, which is very different. Have written procedures for emergency suspension of work if you need to do that. You, as the infection preventionist, really does have the authority to walk by a construction project that is not safe, to close the project down and say, we just need to halt this, it's not safe, your barriers are not intact, and you really have that authority. So you can utilize that if you see something that needs to be addressed at that point in time. So we're going to go through for the next few minutes just the format of this standardized form that I believe all of you guys are familiar with. And the first step is to actually identify the type of construction. It's really simple. When you get into this, you can use the format and work through it pretty good. It tells you exactly what you need to do. So the type of construction ranges from A to B, and it goes from activities that are going to be from nothing but going up and looking at the ductwork to see if everything's intact, all the way down to major demolition and construction activities. So based on whatever type of activity you decide is going to be undertaken, then there are specific guidelines about what you must do. So first of all, we look at the type of construction, whether it's going to be small scale or high scale. And then the next component of that is to look at the risk level. What kind of patient risk groups are you going to be addressing in your construction activities? Is it going to be low risk, which includes office areas? Or is it going to be in the highest risk areas of your facility, like your oncology unit, your OR, your critical care area? So once you define the level of activity, the next step will be to identify the level of risk that it may pose to your patients and healthcare workers. They also must be certainly included in this. So once you've identified that, then you complete the risk matrix, which again is part of your standardized format. Your activity is at the top. It goes from low to high, type A, B, C, or D. And then your risk group is on the axis and goes from low to highest. So you can see how that matches up then. If you have a low risk group, and they're going to have a type A activity, which is a low scale activity, then when we get to the next components of this, it's going to tell you exactly what kind of precautions you need to have in place. But if you go down here to the highest and you have a high level activity, construction activity, and you're going to be doing that in a high risk area, then there's a lot more precautions and considerations that need to be made. Now, just because of time, because I think I'm running close on time here, we're not going to go through each one of these individually because, again, I think you guys are probably familiar with them. Let's see. Amy, I think, did you take control of the screen back?
No, you're back there. Evelyn, I was just going to, if I could just check in for a minute.
Okay.
The environmental cleaning talk is how long is that?
So we have an hour on the agenda, which we probably won't need quite an hour for that.
So if we, added 15 minutes, and ended at
12?
Noon and came back at 12:45. Anyway.
That would be fine with me. And I might not need a full 15 more minutes, but we can do that because I don't believe our environmental care talk will be an hour.
So you don't have to feel like you have to rush.
Okay, cool.
Let me also jump in and say there's a question. Strong construction supervisor that you referred to, is this an internal engineering staff member or the project manager for the construction team?
So it really should be your internal person. If you have someone like that in your facility, because they have a lot more ownership, I guess you might say, if they are a member of the hospital group. So you really need someone strong internally to oversee those consultants and contractors and the people that you've outsourced your construction project to. And I know that's difficult, and sometimes you might not have an individual like that. But that's really ideal if you can have someone internal that's going to help support your recommendations that you make. So does that help?
Evelyn, here's one more question. Where would you say materials supplies falls in risk? Where would you say materials supply falls in risk areas?
Yeah, so I think they're asking about areas that like your central storage area, your supplies that come in from the dock area, and then they are taken out of boxes and transported up to the units. And that, unfortunately, is not specifically identified in the little risk matrix, but we've always considered those at least medium risk. I think they're certainly higher than low risk, even though they're not they don't provide any sort of clinical care. They certainly are the repository for all of your supplies that are going to be used up in the clinical areas. And as we saw earlier, if there's construction activities going on down there and they can contaminate some of those supplies. So I think I would consider them at least medium risk in your matrix, and then base your precautions on the level of activity of construction that's going to be performed and it's going to take place in that particular area. But I would consider them at least medium risk. Okay, so let's see if I can advance my slides now. There we go. So in the standardized tool that we have, this is kind of what it looks like, and it shows you what the precautions are by the class. So remember that if you are a low risk group, like you're in an office area and you're doing very low risk activity, you might be repainting, there may be just some minor repairs that need to take place, then you're going to, your precautions class is really going to be around a 1. And if that's what your precautions class is going to be, then the things you want to do is minimize raising dust, and that might include something like spraying or wetting areas that might have dust on them before you clean the dust. You also want to make sure that any ceiling tiles that have been displaced are replaced and then they're put back into their location. Also in your policies and procedures, in case I don't mention it later, you need to spell out exactly how many ceiling tiles you're going to allow to be removed at one time without using some sort of contained barrier while that activity's going on. So how many, is that 1 or 2, or how many are you going to allow to be removed while that activity is going on? And so during construction, that's the kind of precautions that you would want to put into place. And then afterwards, you do need to clean the work area. I'll mention this, I think I mentioned it in the environment talk, but you also need to be very clear on who does your cleaning after construction activities. Is that going to be the cleaning crew, the construction crew, or is that going to be done by your environmental service people? Typically what we see is the construction crews are responsible for cleaning up at the end of their shift or in between their shift if there's a lot of dust generated. And then certainly at the end of the project, your environmental service people are going to come in and do a terminal clean of that area. And it really should not be opened back up for work until that's taken place. And also not until you guys have had a chance to go up and check off that it meets the requirements. So if you are a level 2 risk, where your risk group might be medium and your activity might be level B, these are the things that you need to think about. You need to prevent any sort of airborne dust dispersal. Again, this might be accomplished through putting some water mist on the surfaces that are being involved. Make sure that if you're working in the hallway or in any areas that there's doors, that those doors are sealed if they're not being used. A sticky mat at the entrance of your construction area to make sure that all of that dust doesn't get tracked down the hall and throughout the rest of your facility. If necessary, seal your air vents and isolate the HVAC system in the area of the construction. Once the construction is complete, if you're a level 2 precaution, all of those areas need to be wiped down with a disinfectant. All the waste, the construction debris and construction material should be covered in a cart with a cover on it before it leaves the construction area. Also wet mop or vacuum the area before leaving, and then make sure that the HVAC system has been restored to normal operating conditions. And you'll notice we said isolate, not cut off the HVAC system. So big difference there. So then if it's a class 3 activity, again, everything that we've talked about for 1 and 2 is going to be included, but there's going to be some additional precautions that need to be taken because now you've bumped up your risk category as well as your level of construction and or renovation activity. So in addition to everything we've already mentioned, construct critical barriers. Again, I would recommend drywall barriers. Maintain negative air pressure in there and use some HEPA-equipped air filtration units to help scrub or clean the air. Again, I've already mentioned, contain all of your construction waste in tightly covered containers. And then once that project is completed, do not remove any of the barriers until the project's been inspected and signed off on. So don't let them take down their drywall barriers until you've looked at it and your internal construction folks have looked at it and made sure that everything is where it needs to be. And then once that's happened and that area has been cleaned, then you can remove the barriers and do it very carefully to minimize any additional dust floating around in the air. Use a HEPA filtered vacuum to clean the area, wet mop the area, and then this again a lot of this would be done by your construction crew, but then a terminal clean would be done by your environmental service department. And once all of those activities are completed, then you can restore your HVAC system. And then the final category that we're going to talk about is the, excuse me. I think sometimes there might be a delay with it. Hopefully it'll move forward. But the next category and the last one is category 4. There we go. And once again, everything that we've already mentioned. So this is a tier. It builds. So you incorporate all of the precautions we talked about for 1, 2, and 3. In addition to that, you want to make sure that any holes that are present around pipes or conduits are sealed. You also, if it's a level 4, remember in level 4, we're doing it in your highest risk patient care areas and we're performing a lot of design work. So in this particular case, when we get here, you need an anteroom at the entrance, somewhere where your construction people can don their garb. They can take it off there before removing the area. They can bring their materials in through the anteroom. So the anteroom at the entrance of your construction site. All your construction people at this point should wear shoe covers, and those should be taken off when they come out through the anteroom, and their clothing should be vacuumed and cleaned off so there's not any dust residual. Once this project is completed, again, do not remove any of the barriers until the project is completed, inspected, and has been cleaned. Take down the barriers, vacuum the area, wet mop with a disinfectant, and then restore your HVAC system to its normal operation. So as you can see, it's a very tiered approach, but this standardized tool is very clear and gives you, it's really hard to argue for anybody in your institution to argue with what you're telling them to do, because it's all right here. It's very clear as to what precautions you need to have in place.
Evelyn,
Uh-huh.
I had a question for you.
Okay.
Who is responsible for ensuring HVAC is protected appropriately? Is it the IP's responsibility?
It's not really the IP's responsibility. It is one thing that you want to talk to them about and discuss, and then you should be rounding in this construction area, and depend on, if it's a level 4 activity, you might want to round every other day, or if you, unfortunately, sometimes you can't trust contractors, and those of you that have done this know this. And you'll go through one day and ask them to do something, and they may or may not do it. If you've got really good contractors that you know are dependable and going to do what you ask them to do, then you might not have to round every day. But if you have some suspicion that they're not going to be compliant, then you really should be rounding every day until you can address it with their supervisors and or managers. So it's not your responsibility to ensure it, but it is your responsibility to find out how they're protecting that. And then when you're rounding, if you notice something that doesn't look quite right, to go to the supervisor of the project and have them address it. And once again, you do have the authority to put a hold on an activity if you think there's a safety risk, because you as an infection preventionist does have to sign that work permit that is posted, and that's the other thing, they need to post that at the construction site, and it has your signature on it. So you want to be sure that you're that they're compliant with what your recommendations have been. Okay, so the next, hopefully the slide will advance here in a minute. The next slide that, I don't have all these printed out, so hopefully we'll move forward. So the ventilation should look like this. It should flow into the construction zone from the occupied spaces instead of flowing out. We all know that. Your location of your exhaust discharges and how those air ducts are going to be sealed. And then your pressure differential for negative pressure. Most large construction activities will actually have the gauges or the monitors outside of the construction area, so you can easily see what the negative pressure is and that it's being maintained. Another easy way, as we all know, is a tissue test. Just you know, if you have any questions about whether negative pressure is being maintained, just put a piece of tissue at the bottom of the area and see if the tissue blows out, blows in, or stays straight up, and that will indicate, give some indication for you about the negative pressure. In some areas, they're going to have more trouble maintaining negative pressure than others. And if they can't exhaust it directly to the outside, they may need to look at other areas, like can they exhaust it through the bathrooms? Most of those are negative pressure, so be a little creative in how to create that negative pressure. And then, let's see. My I'm sorry, my slides are a little slow advancing. So this is a good example of what you should not see, footprints with dust outside the area. And you know, it's really easy to track these people because these are very clear on the floor when they don't get their feet cleaned off well. Again, you can see the dust. This is all construction dust up on top of lockers that needs to be addressed and cleaned. This is what your construction site should look like. Again, that's the work permit in the green. And even though we have those big do not enter signs, somebody will inadvertently go right through there because it's a quicker way to get where they need to go. And we've actually had people cut holes in those plastic barriers. Like, if we didn't put a door there, it means we don't want you to go in there. So these are things that you can look for. This is ductwork. Clearly, there's not a tight seal there. It's certainly not intact. So that's a risk. Another photograph of an area that has been pretty well sealed off, and this is what you kind of want to see. You know, oftentimes that plastic at the bottom we see flying in the wind because it's lost the seal at the bottom, but that in this case looks pretty secure. These are the tacky mats, and there's a couple of different kind. You know, you can have one mat and a kind of an adhesive type surface that you can remove. That kind of helps not changing the actual mat every time, but you can take off the top covering and get rid of a lot of the dust that way if you do it in a manner that you're not going to aerosolize it. This is, you know, not really what you want to see. Again, you need to have a policy about how many ceiling tiles. There are actually some guidelines for that that talks about square foot of how many ceiling tiles you should have out at any one point in time adjacent to each other without having a contained unit. This is a big old mess. That's about all I can say about that one. Some more photographs we'll go through here pretty quickly. This is an example of where they're exhausting it through the ceiling and hopefully directly to the outside. But as you can see in this case, it looks like they've left some sort of equipment in the room and boxes, and which is not really good. This is not what you want your construction area to look like. There's a negative pressure gauge. And this is a photograph of how they're sealing the vent, which is actually a pretty good, you know, they're just putting a little filter on top of that HVAC vent to isolate it. And then remember that even though they might just be going up in that ceiling tile to look at ductwork, there's lots of spores sitting up on top of it that if those are dispersed, can certainly do some damage. There are all sorts of mobile containment units like you see on your slide on the left-hand side, which are on wheels and portable and can be used for these types of activities. We've already talked about education and training, so we'll go through that again for time's sake. Water management plan. Dr. Vitale is going to talk tomorrow more about water management and mitigation strategies for water issues, but I think most of you are familiar with CMS's focus now on Legionella in healthcare facilities, but not only Legionella, but other waterborne pathogenic organisms. If you've not been involved in your water management plan, I suspect you have, but if you've not been, I would go back and ask the questions about what that looks like and who has oversight of that. The CDC, which I think is on the next slide, has a great water management toolkit. This is just a little screenshot from that. It's very, very comprehensive. And so it's an excellent resource for you to use when developing your water management plan. And then these are just a few of the sources of water in healthcare, and we've learned a lot about water this week, but all of these can be a problem in certain situations and be the source of infection and or outbreaks, and if you've ever had some sewage backups in your facility, it's not pleasant, but it certainly does happen in hospitals. Mold remediation, especially depending on the part of the state you live in, and we've experienced our fair share here the last couple of months with hurricanes and water intrusion. But certainly we know that that's going to initiate mold growth and can certainly compromise the health of our patients and cause a lot of the problems that we see with construction and renovation as well, with fungal illnesses. And in North Carolina, we actually, a number of years ago, SPICE, in collaboration with infection preventionists across the state, developed some mold remediation and water management guidelines, and it's called, on the next slide, if I can get it to move forward, the North Carolina Guidelines for Moisture Management and Mold Remediation. So it's a document that's pretty comprehensive, and as you can see, was done in collaboration with a lot of other professionals. It's available on our website if any of you guys would like to take advantage of looking at that. If you need to update or develop a mold remediation plan, it may provide a template for you to do that. And then these are some things that you want to look at about concerning mold. Again, I think Dr. Atala will go into some of these. One of the biggest things that we need to deal with is how long your building materials have been wet. And if they have been wet for more than 48 hours and cannot be completely dry, they need to come out. And sometimes your construction people don't want to hear that, but they need to be removed. So that's one of the biggest things that we get involved in, is how long have I got before I got to take this drywall down and remove all of it. And there are all sorts of moisture meters now that can help your construction folks evaluate how wet the wood really is. These are some things that we have included in our remediation plan policy that you can take a look at, but these are what your plan should include. Certainly use of personal protective equipment when you're cleaning up some of those areas is essential. And then the next slide is one, you can download this from CDC. It's actually a nice little checklist of some of the easy steps to clean up mold. That's on the CDC website. And then in summary, I guess the main thing hopefully you can take out of this talk is that you've got to be involved at the beginning to the end. You really, really need to be involved. And it is a common challenge because oftentimes you do not get the administrative support that you need. I've seen this happen. I know it happens. And the only advice I can give is just keep plugging away and use the guidelines. Use the guidelines to help get your points across. And then the last slide is a comment that was made in Dr. Atala's paper. We can get it to move forward. And I'm probably a little impatient, but it's important for infectious disease physicians and infection preventionists, in collaboration with building contractors and other associated departments, to appropriately implement risk assessment and mitigation measures and prevent healthcare-associated fungal outbreaks and infections. So we as a group are really charged with that. So thank you. I am sorry that I went over, but we'll make up that time. Amy, do you want to give them a little bit longer for lunch?
Right. So I think what we'll do is try to start back at 12:45, and maybe just a smidge later, 12:50.
Okay, that's great. And then we'll stay on time that way.
Got a couple of chats here.
Okay.
What if a ceiling what if it was a ceiling tile that was wet for a while? Do they simply remove the tile and then okay, or do we need to further assess for moisture above that?
You need to further assess for moisture. There's got to be a reason the ceiling tile was wet, and oftentimes the reason it's wet, the leak might be coming from somewhere distal to the actually wet ceiling tile. So there should be a thorough assessment above the ceiling tile of where that moisture came from.
Okay, great.
And it should be discarded and not just cleaned, the ceiling tile itself.
Right. Okay, well, I think we're good, and we will get back together at 12:50.
Okay, thank you guys.